Hello, and welcome to episode 8 of the Security Nurse Podcast. I'm your host, Sarah Marie. It was my pleasure and a real lively conversation today with security consultant David Corbin. David has over 30 years of experience in designing and implementing innovative, tailored security solutions for organizations across a wide range of industries. He is also a recognized thought leader in the field of healthcare security. He is the author of Healthcare Security Field Manual, Patient Violence Prevention and Mitigation, and the Healthcare Security Field Manual, Community Care Site Security, which have been widely praised by healthcare leaders for their practical, actionable guidance. He is a certified protection professional, a certified healthcare protection administrator, and a crime prevention through environmental design specialist. His consulting services include comprehensive risk assessments, workplace violence prevention program development, which we talk about a lot in this episode, security operations improvement, security technology integration, and emergency preparedness planning. And I can honestly say, after knowing David for a little over a year now, he is an avid advocate for you and your staff when it comes to violence prevention, and definitely somebody that you want on your team. So, thank you again for joining us today. If you like today's episode, please take a moment to like and subscribe to the channel. By liking and subscribing, it helps get the knowledge out there to everyone. Thank you again and have a wonderful day. David, how are you today?
Good. How are you?
Good. I'm doing really well. I am glad that we finally got a chance to sit down and officially talk and meet. We've done a lot of exchanges over even like the last year, I would
Oh,
say.
yeah.
Yeah, so I really enjoy, our exchanges on LinkedIn and learning from you. So I'm glad that you are here today with the podcast.
Yeah. Thanks for having me. Appreciate it.
Yeah, so let's get the first question I have really for everyone is because I just like to know, what makes people tick. And so my first question for you is what was kind of like that aha moment in your career that kind of has led you to what you're doing today?
In my career, I would say, I started my healthcare security career as an investigator. I was contract security investigator at Brigham Women's Hospital, and I actually had no healthcare experience. I had no idea what people in a healthcare investigator role investigate, and all my friends would ask me, like, what do you investigate at a hospital? And I soon found out a lot of things. But one of the things I started to realize in that role was that workplace violence was an issue. And shortly after I had that role, I moved into a training and special projects manager role where I was developing training for clinical staff, especially like techs and some of the other patient care assistants, folks like that. And I had to design some training for them, and they wanted training around de-escalation workplace violence. And I started to realize, again, sort of new to healthcare, that my sort of role was mostly focused on investigating thefts and non-workplace violence things. But I started to figure out, like, workplace violence is really a major issue, but it didn't have the attention that it has now, right? It's always been happening,
Yeah.
but obviously the frequency and the severity of it have increased, substantially since then. But it was a problem back then, but didn't have the attention that it needed. I started to figure out, since I had this, these trainings that I had to put together, started to do some research, and I started to find like some of the initial OSHA publications and some of the other old school sort of publications around, and I started doing research. I'm like, wait a minute, this is a problem. And since then, I've really dedicated a lot of energy in my career towards preventing and mitigating workplace violence. So initially as a practitioner, and now as a security consultant, a lot of my practice is focused on workplace violence prevention and mitigation. So that's kind of how I got my start. That aha moment really came sort of just by doing some of the work and talking to folks who were in those roles and realizing that this was something that they were worried about when I was being told by my leadership, like, oh, our theft is the biggest issue in this hospital. I'm like, no, but look under the covers here. We have a problem. Look behind the curtain. There's another
Yeah.
problem brewing.
Yeah. So when you say back then, so I want to kind of clarify a timeline. No, it's okay. Well, okay, so I started nursing in 2006 and I was in Cincinnati, Ohio, and I can remember probably like around 2009 getting like a mailing from a union that was trying to form a union in Ohio. It didn't really work very well. But that whole little flyer was about the violence that, nurses are experiencing. And this was, like I said, 2000. And I remember kind of looking at it and I was like, what are they talking about? Like workplace violence? Like, for nurses, like what? And then like now, like fast forward to now, and we can dive into this because some of the studies show that the reason nurses don't report it is because they don't understand the gamut of what workplace violence is. And so I can laugh at myself, kind of like, haha, that's what workplace violence is. So when do you feel like, because you said something else about how it wasn't given the attention. So when was it that you were kind of like, aha, this is like a bigger issue? And then when do you feel like it really started getting the attention that it needed?
I think, so this was around 2000, 2001 that I'm talking, that I was doing this work.
Okay.
And I started to do these trainings, and I saw that more people were interested in them. And then I moved from that role into a more, operations role, and started seeing for myself the violence that was unfolding sometimes in my direction. So I went from on the sidelines, like, hey, I'm an investigator, I'm a trainer. Then I'm like, I'm a victim of workplace violence. This is happening. Well, I'm watching other people get injured, and just the chaos of it all. And I'm like, this is nuts that this is happening here. And I started my career in retail loss prevention, so I was no stranger to violence, violent shoplifters and other kind of crazy stuff. I could write a book on that, but
I think you should,
but
but
yeah, I could write I mean, someday, like when I'm far past my retirement, I should write some kind of a book on adventures in healthcare security,
yeah.
protecting the names of everyone, of course. But yeah, I mean, I'm sure anybody in healthcare could write something like that. It's just insane. But in terms of when I really started getting my arms around it, and when I really started to address it in a way that I felt like it was the right way, was when I had my first security director role. I was at Faulkner Hospital in Boston, and I was a young director, and I was like, I want to put together a program around workplace violence. I want to get training out to all of our staff. I want to make sure that we have a workplace violence committee. So I stood up a workplace violence committee there. We had a very unique training program there that it didn't start immediately when I got there. It needed the backing of the C-suite, and we needed commitment for funding. But eventually we got to a place where every month, we were doing a 2-day, 16-hour training for clinical staff, security staff, anybody else who was at risk, determined to be at higher risk. And so that was 2 days of management of aggressive behavior training, plus some trauma-informed care training, plus some simulations, and some really, one of the best parts of it was some really good discussions. So
Yeah.
we trained clinical and security staff together.
Okay.
And it was funny that the Moab class only needed to be, I think at the time it was required for 2 days, it was something like 12 or 13 hours. But then the nursing leadership was like, well, we can't have somebody here for 8 hours one day and then, not 8 hours. And they have to work a full 8-hour shift. So we're like,
Yeah.
okay,
Yeah.
now it's 16 hours, which is a lot of training, but it really made a difference. And the conversations that happened in those classes between security and nursing staff, like, it was a great relationship builder, but also people asked the questions like, is the hospital going to stand behind me if I use a palm heel strike to somebody's face? It's like, yeah, they are, as long as it's justified. We talked about when to use it, but also I saw the hesitancy of clinical staff. and even security staff, honestly, to defend themselves, even if it was a life or death situation. They were still questioning, I use the, can I punch somebody? Can I kick somebody if they are choking me to death? And if you were on the street, you wouldn't be asking that question. Am I going to get in trouble for, not dying while I'm being
Yeah.
choked to death? But it's a real calculation that people are doing, that security, clinical staff, they're like, nobody wants to hurt a patient, right? Nobody
Right.
wants to intentionally hurt a patient. That's why people got into this role. They're trying to help patients. So it goes against people's thinking and instincts. But it was interesting to hear the thought process of, like, even if my life is in danger, I'm not sure if I'm going to defend myself. It
Do you
seemed like
think,
crazy to me.
yeah, do you think it was more like, or maybe it was just kind of a combination of the both. Do you think it was more like hesitancy because they didn't want to hurt somebody, or was there a lot more hesitancy because of like fear of like losing license and having hospital retaliation and losing your job? Which
Yeah,
do you?
I think it was two. I think it was twofold. I think it
Yeah.
was personally they didn't want to do it. And then on top of that, and sometimes greater than that, was, am I going to get in trouble for this? Am I going to get fired if I defend myself? And again, from my standpoint, I'm like, no, and I actually went to leadership and checked. And they're like, no, we will stand behind these folks. It's kind of like when staff get active shooter training and they're like, well,
Mhm.
I can't leave my patient, right? If somebody is in the hallway with an AR-15 and I have to stay with my patient. And it's like that mentality of, some people are thinking, because they're my patient and I've dedicated my life to this, I will stay beside them. I'm not going to abandon them, right?
Mhm.
And then other folks are thinking, I'll get in trouble for
Mhm.
saving my own life. It's kind of like that same mentality.
Yeah.
It's almost like they're not sure. And I used to tell people in active shooter training, if you can't even consider leaving a patient behind, then make that your mental plan today, right? If I hear gunshots, I am going to hide, barricade the door in the patient's room with the patient, right? Don't even think of the run part, because you're not even going to do that. Don't slow down your thinking. Just make that a part of what you're doing. It's the same thing when you're training on de-escalation and defensive tactics, is to say, like, if you can't see yourself doing this, then start to think of alternatives, right? Even if I give you this training, if the hospital backs you and you still can't do it, then you have to figure out what's the alternative.
Yeah. What's your plan? What's your and a lot of it, and I would teach self-defense to young women, most of them survivors of domestic violence. And that was one of the exercises that I had people go through. Like, one, like, what's your values, right? So
Yeah.
identify your
Yeah.
values. So maybe if you value your family and your kids above all else, you might be able to see yourself running and that patient stays there, but you're gone. And I work with several nurses and other places too that have said, nope, I'm gone, I'm out of here. Like, they've
Yeah.
already like envisioned that
Oh,
and
yeah.
have made those decisions, which kudos to them. I think for me, I would be the person that would have a hard time leaving. So now I have kind of formulated, all right, well, where are some weapons of opportunity here in the emergency room, and what are we doing if it's in this room or that room, and creating those plans. And you're absolutely right, because what it does is that slows down your speeds up your reaction time, right?
Hmm.
So if you are stuck with which way do I go, what do I do, that causes a delay in your reaction time, which could be very, very costly. And so absolutely, in these trainings, creating those scenarios and that mindset, it's really a mindset.
It is. It is. And like you said, that programming is key, because any second you lose in the decision-making process is potentially going to result in you getting hurt. So yeah, I think that, but it was crazy for me when I first started seeing it, like, these folks they're not sure if they can protect themselves. And it just seemed nuts to me. It's like, of course you can. I'm like, if you were on the street, would you do it? Yes. Then why won't you do it here? Right? Well, I don't want to get in trouble. It's like,
Yeah.
for saving yourself from being choked to death. No, I don't think you'd get in trouble for that. And if you did, you should probably not work here, because this place is nuts. But that wasn't the kind of place it was. But even when I'm like, someday I felt like I was going to bring in the CEO and be like, will you come over here and tell these people, or the CNO, somebody come up here and tell these people it's okay. It's like, they didn't believe it. Some people wouldn't believe it if they heard it right from the CEO's mouth. It's just that level of disbelief. And again, you just had to kind of train them around that to say, all right, then come up with a different plan. Even if it's going to be, I'm not going to get in a hands-on situation. I'm just going to extract myself and get out of there or escape, whatever it is. But you have to have some plan. You can't just say, I'm just going to, you know, be victimized by this person. It has to be a different plan.
Yeah, and that really helps with like the healing after the trauma, right? When you kind of have that plan ahead of time, because you can really just beat yourself up afterwards with like, well, maybe I should have done this and I should have done that and I should have, shoulda the shouldas, right? And so having that plan can really help with kind of that self-care and that healing like after an event, really knowing and being at peace, like, okay, I know that I did X, Y, and Z to the best of my ability, and a lot of other stuff is out of my control, right? And that's the hardest thing, I think, kind of about violence. And I train with Tony Blauer
Oh, wow.
with Spear. And so, one of his things one of his mantras that he really says is that, the bad guy chooses the fight. You don't get to choose the day or the time that violence happens. The person that's going to perpetrate the violence is the one that's initially in control and gets to decide when that happens. And that's why we train, is to then kind of have a little bit of that control, if it's even, if you can even call it control, back, because with that training, it gives you choices and it gives you a say, right, in how things are going to go. So you were doing those trainings every month?
Every month, sometimes twice a month at the beginning, and then every month. And we would run refreshers as well. Usually, like every other month, we do like a refresher too, like a 4-hour refresher. Sometimes
Would
8.
everybody participate every month, or did it kind of like rotate a little
It
bit?
rotated, but we were trying to get all the nurses and all the clinical staff. Of course, we couldn't get any physicians in there, which is a common issue. You're laughing because you know exactly what I'm talking about. Couldn't get the providers. I'm like, you should also have this training, but trying to get them in there it became impossible. So it's
Yeah,
just like,
really
okay,
tough.
get all the
Yep.
nurses, get, techs, PCAs, people with direct patient interactions, we'd get in there. And sometimes I'd get people who didn't have as much risk exposure that wanted to do it, and the hospital was very supportive of it. I mean, when you think about if you went to a hospital today and you were like, all right, folks, we're going to do a 16-hour training class every month, and we're going to pay people for it, and we're going to have coverage. It's like, no, they're going to do a 1-hour online training, and if you can get them in person for 4 hours, you're lucky. But it
Yeah.
was a different time, different, economy, and staffing was good, and it was a very supportive hospital environment. Leadership supported it 100%. And, I wish at the time I had like that, the sophistication around, key performance indicators and like tracking the data around it.
Mhm.
But, I felt like people barely reported workplace violence at that point. It was only the more severe, like now, it's like, physical violence. If you're hurt, if you end up at Alc Health, of course, it's going to get reported, or if it's a threat and you're fearful for your safety. But a lot of the other low-level stuff wasn't being reported, and there wasn't like a separate module in our safety reporting system to report it. I mean, even the reporting systems at that time were pretty, cumbersome,
Yeah, time
and
consuming.
yeah, they weren't really
Yeah.
like they are now, like click, click, click through. It was very like archaic kind of reporting system. So.
Yeah, I think so. A lot of them I've seen, they are a little more like kind of click, 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 but they still have that box for like the description of what happened. And I think, and
Like, I don't have time for this.
yeah, I don't have time for this. And actually, kind of touching on that, one of your posts a little while back, you posted a study where somebody has finally used AI to look at all the like nursing
Yeah.
charting and the nursing notes. And I was like, yes, this is going to like totally change how we kind of start reporting on workplace violence and tracking that data. Like you said, like there's some things where like I'm just like super excited for AI, like in healthcare. And then there's other things where I'm like, well, maybe that needs a little tweaking. So, and actually there's a bigger discussion, like, can you call it an AI nurse? Right. And so
Oh, I saw
now,
that. No.
yeah. No, no, it should not be called an AI
Yes,
nurse.
I'm having a heart attack. Call the AI nurse. No, no, I don't need the AI nurse now. I want an actual nurse.
Yeah, yeah, exactly. So when you were when you were forming this program, and you talk a lot about it, and maybe you can kind of elaborate because now you're consulting with other hospitals and things like that. You talk about, setting kind of a centralized person to have ownership over the workplace violence. Can you expand on that?
Yeah. And this is like, this is like my my dying on the sword kind of thing. I refuse to let it go. Um, what I have found is that oftentimes the security director ends up with the workplace violence program. Did they ask for it? Probably not. Were they told to do it? Maybe even not. Maybe they just figured out, hey, my predecessor did this, or, it's expected almost, right? And I think for a while it made sense, right? It's based on what we knew about workplace violence. Security is the one who responds, and there wasn't a whole lot of evidence-based intervention research out there around what works and what doesn't. I mean, the more of a problem it becomes and the more prevalent it becomes and mainstream it becomes, it's in the news, it's everywhere.
Mm-hmm.
There's more support for research and other techniques and tactics. Not that there weren't any back, earlier on when I was talking about, but there wasn't as much information. So I think for a while it made sense. But when you really look at the numbers, when you really look at where the workplace violence is coming from, 90+% is coming from patients, patient-generated violence. It's happening at the bedside.
Yep.
Right? Probably not happening in your waiting room. They're cursing at you in the waiting room, but patients are not attacking people in the waiting room usually, right?
Rarely, yeah. I mean,
Yeah,
we'll
yeah.
see
It's
the
at the
occasional,
bedside.
but yeah.
It's at the bedside, and that's where the violence is happening. And a lot of the factors contributing to that relate to their condition, their clinical condition, the treatment plan, and a lot of clinical factors factor into that. Can somebody have criminal intent? Absolutely. They're just somebody bent on hurting somebody because they want to, or committing a crime against somebody because they just hate them, or what. But a lot of these, vast majority of these assaults are, born from some kind of clinical issue, right?
Right.
And none of that, in my mind, excuses the fact that they committed violence. They all have different reasons, right? But violence is violence. If somebody has dementia and they punch you in the face, it's not like it didn't hurt as much because they have dementia. It still hurts,
Right.
right? Are you going to prosecute that person? Probably not. And if you try, it won't be successful. But it still hurts. It's still violence, and it still needs to be addressed, right? And I don't think it's all inevitable. Like people just say, "Oh, it's part of the job." It's so. All that's to say that I believe, in order to properly address workplace violence, first of all, you need one accountable leader, right? And in many cases, that's the security director, or it's been pushed over to the workplace violence committee. It's like the security director is driving in the boat when the committee's not meeting, but the committee's kind of like setting the course. But the problem is the committee meets once a month, maybe every other month.
Mm-hmm.
And guess what they're working on when they're not doing that? They're not working on the plan. They're coming back and saying, where are we with this? Listen, I've sat in so many workplace violence committee meetings, I've led them, and you keep having the same conversation
Conversation.
every
Yes.
month. Where are we at on this? Oh, let me check on that. Or I'm not sure where we are with that. Oh, we're still trying to get this done. And what they're saying is, I haven't worked on anything since this last meeting. And it's not for lack of wanting, it's lack of time, right? I have 200 other things I have to worry about, and this is one of them. So that you lose momentum is what I'm saying when you have those led by committee situations. And then it's kind of on the security director, sometimes like a safety officer or whatever, to run that program in addition to everything else they have to do. And I think that having one accountable person is key, and having that person be somebody with a clinical background is even better. Right. And I also will say somebody with a clinical adjacent background. Maybe they're in charge of risk management, but they have some sort of previous clinical background. Maybe they're not a practicing clinician. Maybe they don't have 20 years of nursing experience, but they know enough about clinical operations and risk factors and things like that they can incorporate that into their practice, right?
Yeah, no, I
Would I
agree.
rather see somebody with a deep clinical background in nursing or psychiatry or something like that? Yeah, absolutely. But ideally somebody with a clinical background, ideally somebody with a deep clinical background. And I've seen the programs out there that are being run by these folks and they're doing a great job. I mean, from what I hear from the results and the way they're approaching things, that they have helpers that are part of that team that are going in and directly intervening and helping clinical staff work through difficult situations. They're not just in the background saying, here's the policies and procedures. They're boots on the ground. They're helping educate other clinicians in difficult situations. They're supporting them. They're acting as an extra layer, not just when something bad happens, but when something bad could happen, or when somebody scores high on the BROSIT, they're helping them figure out the acute care plan or the treatment plan, or mitigating tactics while they're there, right? So you have to be able to talk the talk with clinicians, walk the walk, and dig in there and figure out maybe there's something going on with the clinical workflow or process or a procedure or something like that. You don't know unless you're really in it and can understand what's happening and understand the barriers to changing things, right?
Yeah.
So I think that's the way of the future. If you really want an effective program, to have someone in a clinically experienced, one person accountable. And if you have an enterprise level, arrangement where you have, 12 hospitals, there should be one person for the enterprise who's responsible for all of that. And then ideally, maybe it's a director at the enterprise level, and then you have managers in each of the hospitals, or whatever your arrangement is. There needs to be somebody in each hospital who's responsible for it, but that should all go up to one central person who's responsible for everything, because you need coordination. And I've seen it with some of my clients. They have somebody responsible in each hospital, but then there's no coordination at the top.
Coordination between
And everybody's
the
doing something
hospitals.
different.
Yes.
Everybody's doing something different.
Yeah. Yeah, I've noticed that too. And then, so I've sat on workplace violence committees, and it's like, okay, so you have your individual hospital one, but who's, what are they doing over there, and why do they have a different policy? And then come to find out, later on too, that then there's even like a corporate level, workplace violence committee.
Oh,
And
yeah,
so,
at the corporation level, yeah. For the
yeah. And so,
offices and yeah.
yeah, and so the decisions came from the corporate level workplace violence committee, and the local level committee, I think, was tended to be more responsible for maybe trainings and kind of rolling out trainings. But it's like you said, it's a hamster wheel. You're like, okay, where are we at? And then it's just having the same conversation. And again, I'm not picking on anybody. I've been on several in different states, and it runs the same. It's the hamster wheel. And so I absolutely agree, like having somebody that has kind of that central, and making an FTE out of it. It becomes a full-time, it's
Yes.
worked into your budget.
Yes.
That this person has that role. And even for some of the smaller, community hospitals, like you said, you could have one centralized person that's over your community hospitals, but everybody has got to be kind of working together, coordinating together, making sure, what works in one area. Because there's, even though you're part of the same system, each hospital, each entity has its own culture.
That's right.
Right. And the demographic in which they serve, the population in which they serve, is going to be different too. So there might be different needs. And it's understanding, like, okay, well, what we need down at the main downtown hospital is not necessarily what we need out in the rural hospital, where it's more farming community and all of that, but making sure that we're still overlapping and supporting each other.
Absolutely. And just as a note, for smaller community hospitals, I mean, most community hospitals are attached to some larger entity, but for some of the smaller hospitals, community hospitals, rural hospitals, they're probably listening to this saying, I can't have a full-time FTE just doing this. Maybe it's a half-time person, right? Depending on the size, if you have like 60 beds, maybe it's a quarter-time person. But make sure, like, if, scale it to your size, but make sure they have a carve-out of time to work on it, right? Because if they don't have that carve-out of time, because anytime you go to a community hospital, like when I have meetings with staff, they'll be like, I'm Bob Jones. I am the Director of Security, Safety, Environmental Services, Parking, Telecommunications, Biomed, and, party planning. And it's like,
You
what?
forgot emergency management.
Emergency management, excuse me. They have like 12, jobs.
Yes.
And you're like, oh, and don't forget workplace violence. But that's what I mean. Like, if you have that responsibility, it should be a carve out. Like, nobody would make you a safety officer in a hospital and then not give you time to do that because it's too important, right? Because there's compliance issues and everything else. But when it comes to workplace violence, sometimes that's what happens, right? And the same thing for security directors. And I'm not saying that there aren't some security directors out there doing a great job running the workplace violence programs. There's folks that have no clinical experience whatsoever and are doing a great job. So I'm not knocking that. I'm saying that if you're in a situation and you don't have that, and if you ask me my ideal situation, that's what it is, right? It doesn't mean that other people can't do it. I just think that if most of your violence is coming from the clinical side and that's where you need to address it, then you should have clinical background and you should have that responsibility. And again, make sure that there's enough time to do that job, whether it's an FTE. And I know that that's like a dirty word these days, right? It's a dirty 3-letter word when everybody is struggling financially and people are getting laid off and everything else. But ultimately, I think that pays back big time. Like if you have an effective program, and it's so hard to get your arms around that. I want somebody to do a study where they look at the actual positive financial impacts of a robust workplace violence prevention and mitigation program. And it's so hard to measure what doesn't happen.
Yeah.
Right? But the cost savings of not having staff turnover, not having, having better patient care. It's like I try to make this case that if your bedside staff, if your nurses are wondering all the time, at what point in this shift am I going to get hit or threatened or spit at? Can you really focus on delivering excellent patient care? I don't think so, right? Because you're always thinking about what if, and you can't truly focus. And listen, I know there's some like hardcore folks out there that work in emergency departments that can just keep trucking. Okay. It's a whole different culture.
Yeah.
But but even among those folks, there's still some people just that are, they're running those mental processes in the back. Even though they can stand up to it, they're still like having to process like what just happened, what's about to happen. And it takes a toll on patient care, I believe. And not to mention lawsuits from liability exposure, regulatory exposure. If staff file a complaint with, your Department of Public Health or with OSHA or with anybody, you're starting to expose yourself to regulatory scrutiny. And if you have a major situation like that results in, near miss death or an actual death of somebody, I mean, talk about the next level of scrutiny. But avoidance of those situations, avoidance of people being hurt, lost work time. Like sometimes I feel like, I mean, the biggest motivator should be you should do it because it's your moral obligation and because you should take care of your staff. But sometimes it has to be also communicated in dollars, because ultimately, if you're going to spend money on this, okay, what's the return on investment? Like your CFO is going to sign off on it somewhere. So you have to be able to make that case and say, yes, it's the right thing to do. And also, here's what it could save us. And I want somebody to do like a real
In-depth
study on what these things save.
Yeah. Yeah, I think as you're talking too, you start to realize, and this comes up a lot too, the silos that everybody is in, right? And so I think everybody is like vying for money for kind of their specific thing, right? So like we know there's better patient care and maybe reduction in violence when there's staffing, right? But we also know that there's better patient care and there's less patient falls when there's good staffing. We also know that there's better patient care and less pressure wounds when we have good staffing. And so I think like all those people are kind of vying for their programs in these silos, and maybe kind of some collaboration, and maybe the study, needs to kind of overarchingly look at all those silos, all those things that we can prevent with better staffing.
Well, what you make me think of is every time I see that there's a near strike or a strike for union nurses, the two top issues that I see are staffing ratios and workplace violence. And guess what? They're related, right?
Yeah.
And they're not saying that they're separate. They're saying that these things are related. Like your patients will be safer if we have better staffing ratios, and we'll be safer if we have better staffing ratios. But those are the top two complaints that like the top two topics that they're striking on, right? That they're really pushing the negotiations on. And, there's a reason for that. Like you said, it's like I think that I'm sure there's plenty of information out there and probably some studies on staffing ratios and how they affect patient care. But ultimately it's, I feel like there are some hospitals out there that, unfortunately, despite all the information out there, they want to do the bare minimum in terms of the workplace violence piece. And I think that's not always the fault of their C-suite. It's sometimes just the lack of understanding and maybe the lack of an advocate within that hospital, whether it's a security director or a risk manager or something, that can communicate it in a way that they can digest it and then see the light, kind of thing. You know what I mean? Sometimes it's I'm that person that's helping the C-suite see the light. I mean, they obviously know that there's a problem if they hired me,
Mhm.
but sometimes I'll meet with the security director at a place and I'll say, "Here's what I found so far. What are the things that you're trying to get done here and that you're seeing?" And I'll tell them, like, "I'm here as an advocate for you, and I'm going to tell you right now that you're probably going to tell me something. I'm going to put it in my report, and then when they see it in my report, your C-suite will move on it. And I don't want you to be upset about that when it happens. It's just sometimes they need to hear it from someone else
Mhm.
in a report for them to get it. So, like, don't take it personally, like that they don't trust you or something, but sometimes they need an outside independent consultant to say the same thing, but in a report. Because, yeah, sometimes people are going to think there's some self-interest in it, that they're vying for these financial resources, but like, how do we know this is going to work, or how do we know this is a good thing? But oftentimes people, they just can't get the information in a way that makes sense to them, that they can move on it. And I do think most hospital C-suites want to do the right thing, but when it comes down to financials and everything else, I think that workplace violence gets lost in the woods when things start getting cut and they become less of a priority. And then I feel like workplace violence gets worse as things get cut, staffing gets cut, you know, there's less time for training. Like,
Yes.
the
Yeah.
worse the financial situation gets in a hospital or enterprise system, the worse the workplace violence. And probably if the economy's bad, then guess what? It's probably going to show up in your emergency department and on your inpatient floors too. So it's like this mess of factors that can really raise the risk factors for violence, unfortunately.
Yeah. Things that are more systemic, I would say, that are kind of out of your control. But again, that goes back to, too, like what the hospital downtown needs may be different than what the hospital down, in the rural areas need. And it's I think a lot of times too, people think, and I don't fully understand it, but thinking that if you're a big system, right, that all the money can just kind of funnel to all these different places. And what I've learned is like, nope, this hospital has their own bank account and this
Oh, yeah.
hospital has their own, and we don't cross bank accounts.
No, no. And when it comes to capital, you have this much capital and you have this much capital, and that's all you have to use. And
Yeah.
everybody's fighting for the same pot of money.
Yep, yep. And so, yeah, and I think, a lot of clinical don't necessarily realize that, right? You don't really necessarily realize kind of where the money flows. And you see that, the CEO got a big bonus and that
Hmm.
kind of stuff. But that's a whole different conversation.
Oh, yeah.
I probably shouldn't have opened Pandora's box going there with that one. But yeah, so kind of understanding that, and I think going back to having like a workplace violence director, and whether that's somebody that is, the whole system, right? A workplace violence director that oversees the whole system with separate managers at each entity would have a better understanding of that. And I think, kind of to your point, that's why it's really important to have kind of that central point person, because they're going to have that understanding.
And I did a presentation recently at a conference, and I have a screenshot. And I think I posted on LinkedIn before, but I have a screenshot of a job posting that I think somebody must have shared it somewhere. It was for a workplace violence manager for Chipotle, the burrito place.
Yep.
And I put it in my presentation. I said, look, even Chipotle has a manager of workplace violence. And I mean, how much violence can there be in the burrito industry, right?
The br-
Maybe a lot. I don't know.
Well, I
Maybe
mean,
there is. Maybe I
people
don't
are
know.
hangry, so
Yeah, I
you
mean,
have to
hangry, but you have
understand.
the antidote, like a giant burrito. Like,
Yeah, yeah.
you
Oh no,
have sure.
I've had instances of near work, well, some verbal. So yes, workplace violence. because people were upset that they didn't have their food yet and they're diabetic and you got to get their insulins covered,
Yeah. Okay.
and they can get pretty nasty and pretty vocal when they're hungry.
But Chipotle, they have, the glass kit. You have the glass to protect you. You'd have to climb over the glass through the beans and
Yeah.
the meat to get to the person. I don't know. But
Yeah.
what I'm trying to get at is, I'm like, you need a workplace violence person. Chipotle has a workplace violence person. You can have a workplace violence person. We're not operating at the same level of risk, okay? And what I realized is that it was a workplace violence manager like in California because of all the law, the OSHA laws around workplace violence
Oh yeah.
changed there. But I don't give that context because I want people to just see there's a workplace violence manager for Chipotle. Like, come on, let's get our act together. But
I mean, there's a reason that California passed that, though. I mean, there really is, that it was needed. And even I have noticed everybody hates being on the phone, right? You got to call a customer service line or something like that. And I had noticed, I think I was in Colorado, and it was my internet and cable provider. And the way they were responding was just so, we're thankful that you called us today and chose us to help you. I'm here to walk alongside you. And it was like, I was like, I even asked him about it because
oh my gosh,
I was so like, hey, what kind of training are you guys doing for your customers? I was like,
walk
because
alongside you. That
yeah,
is
it honestly sounded very trauma informed. I was like, okay, you guys have been doing some trauma informed customer service training here.
oh
and
yeah.
and he was like, oh yeah, we go through this extensive blah 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 blah. And then I noticed it with T-Mobile. I had to cancel my T-Mobile because I was going to bundle, right? So I was canceling my cell phone to bundle with the other company. And even the T-Mobile guys, I was like, did you guys all do the same training like at the same time? Like, who's rolling out this customer service trauma informed training where you're going to walk alongside me? So but honestly, like, because I was having, there's that hesitancy of like, oh, I gotta explain, and they're gonna try to rope me into, no, stay with us kind of thing. And there wasn't any of that. And I don't know if it's because somebody did the study and rolled out like, hey, if we're more supportive of like, oh, we're sorry to hear you're having financial, situation and you have to cancel our service or something, then people are more apt to come back, right? Or at least just give you like a good review on Google saying, hey, I was able to cancel this and they were really nice to me. And, so if you're thinking about using them and you can, go for it, kind of thing. But I think that that's good. It was really good customer service. And I know that we sometimes, we have started in healthcare doing customer service. I remember going through those trainings probably around 2010, when it was like, they're not it's not patients anymore, it's our customers. And for clinical staff, that was like, they're customers now. um that's like another like disconnect, I think,
Oh yeah.
that was difficult for clinical staff. um and back to kind of that workplace violence too, when you get, maybe somebody that was like prior military or prior law enforcement that come into that security role. And then you have these clinical staff that are just kind of like, well, I'm not going to fight back, and I'm not going to, there's a difference in like a meeting of the minds and a mindset there. Have you run into some of that?
Oh yes. Yeah. Well, I would say that I've had to help
Right. Not
people.
personally, but in your
No, but I'm
consulting.
talking about people who come in with the law enforcement mindset into a security role and need to have some deprogramming, for lack of a better description, that, the things that worked in your last job are not going to work here. Like, I've hired corrections people, I've hired law enforcement folks. I'm not saying it's everybody, but I've had some folks that I'm like, you taking a hard line with people is not going to work out, because guess what? These people are not leaving, and you're going to have to deal with them over and over and over again. And the worse impression you make at the beginning, the harder your job is going to be, and for everybody else, and you can't go to physical, immediately. And it's a whole, you're going to be doing a lot of de-escalation, folks. And so I think there's a deprogramming that needs to happen. And in some cases, and just letting them know about the reality of what this job actually is, that, just going back to customer service, what you're talking about is that's where de-escalation start. Like, what do they call it now? They call it non-escalation, right? Somebody came up with non-escalation. I want to come up with something that's before that, by the way, like pre-non-escalation or something training.
We'll work on that.
While
We'll
you're
kick that
sleeping, you're
around.
meditating about how not to escalate someone. I'll figure out something. I'll come up with
Well,
an
I
angle.
think it starts with self-regulation.
It does. It does.
Right. Yeah. And the other thing, like the thing with self-defense, the very first word in that is self, right? So managing yourself first before you go into the defense. And that can mean various things, whether it's your emotional state, your mental state, your physical state, right? I hear a lot of law enforcement guys that have moved into healthcare security say they're more hands-on with the healthcare stuff. But to your point too, like they can't necessarily take that hard line, right? So they're hands-on, but they can't necessarily take that hard line that they did in law enforcement, public law enforcement. And so they talk about kind of the change, how much of a change it was for them to come into healthcare.
Yeah, it's a major shift. And yeah, and just getting people on the customer service piece to be able to, like, yesterday, was it yesterday? Yeah, yesterday I had to go get blood labs drawn at a hospital, and I went in there, and there's like the person in the registration booth is like over in the corner for some reason. They're not at the front, and they're like, "Can I help you?" Like yelling from the corner, no eye contact or anything. And I'm like, "Oh, hi, I'm checking in for what?" I'm like, "For the labs." Like, that's the only thing that's here. It's just like, just so grumpy. And then I get called into the back, and very nice lab tech brings me in the back, and then I'm standing there because there's like a, what do you call it, a little tourniquet thing that they use, that the rubber band thing
Yeah,
that they,
tourniquet.
thank you, and they put it, and it's on the seat, and I'm just like waiting for her to clean it off, and then she picks it up. I sit down, and she just looks at me. Like, she doesn't give me any instructions. Like, I've had my labs drawn before, but I'm like, you want me to pick like which sleeve? Usually they're like, roll up your sleeve or something. Nothing.
Yeah.
Just staring at me. I'm like, am I doing something wrong here?
No.
So I'm like, start doing my sleeve, and she's just like, man, doing it. It's like no explanation, and it's
So something was kind of going on in that
weird. One
department
woman's
that
yelling
day.
at me, and the other one's
Yeah.
saying nothing
Yeah.
at all. But it's just like that, if people don't not like getting their labs taken, which is the reason why people pass out while they're getting the blood drawn all the time, right? People do not like it. So, the actual draw experience was fine, but like going in there was not calming at all. And to have no instructions whatsoever. I wrote recently about a LinkedIn post about going to a dermatologist's office where they explained everything like almost too much. I thought I was like in the Twilight Zone. They're like, I am going to take a picture of your mole now with my iPad, like, and it's going to go into your record. And I'm like, this is okay. There's like a level at which this might be too much, But then afterwards, I was like, that was like, if you were really anxious, like I was anxious, but I wasn't like at level 10, maybe I was at 7. But if you were super anxious, having all that is great. Like, lots of information, what's going to happen next. Okay, I'm going to leave the room. I'm going to go get this. I'm going to come back. And then when I come back, I'm going to have this person come in. This is what they're going to do. And before they make the decision, I'm going to do a little incision. Let me know. It was like, holy moly. It was like, I've never experienced anything like that level of explanation.
Yeah, that's honestly my practice, is doing that in nursing. And I also try to be realistic about timelines too. And so I think sometimes I've gotten myself in trouble with, some other staff, but I've also said, like, hey, let's be realistic about the timelines, right? Because I know that this is, because a lot of times, like, especially like me working night shift, a lot of the questions I get, like, how long is this going to take? It's like the visitor too, right? Like, I only live like maybe 5 minutes from here. Do you think I'll have time to maybe go home and sleep a little bit and come back? And I'm always like, oh, like I can't, like I hate to like
Oh, yeah.
I'm upfront with them. Like I said, look, I hate to like say yes or no. Here's the amount of information that I can give you. Here's how it usually goes. Like night shift, it
Hmm.
can take a little bit longer to get results because there's less people reading your radiology reports, and that's nationwide. That's what happens on night shift.
Yeah.
Um and so, here's all the information. Now you can make the best decision that you think, is best for you right now. And a lot of times like everybody like really appreciates that, and you curb a lot of the anxiety or
Hmm.
the unknown when you do kind of over communicate, and I think give people scenarios on which way it could go, right? And so I've always found in my clinical practice that that's actually been kind of a superpower to have, and to kind of set those expectations of kind of like, well, it's a range, right?
Yeah.
It's there's a gray scale here. I know the plaque on the wall says you'll
Yeah.
get your CAT scan results in 60 to 90 minutes.
Yeah.
But there's a range here, and everybody, like, so far I haven't had any problems anywhere I've ever worked. Like I said, usually it's with, and I love my physicians, but usually it's with the physicians. Like, why did you tell them that? Because I know that it seems like we should tell patients like less information, but we really shouldn't. We should be giving them more information. And now I think physicians are kind of more understanding that and kind of seeing that, because now everybody has Google, right? So everybody's going on Google and like looking stuff up, and
Yes.
so now you're de-escalating what Dr. Google told this patient and giving realistic expectations around that. And so again, explaining to patients, okay, well, Google, doesn't have all the information when they answered that question, and looking that up. And so, but it's just that collaboration and working with people.
Yeah. It's huge.
What are some of the blind spots that you have come across kind of like in your consulting, where programs where you kind of said, hey, let's look at this? Does it seem like there's kind of a common, or even just a few?
Yeah. I would say typical blind spots. First of all, the ambulatory or community care sites, whatever you want to call them, don't like get the love from security generally. And not for lack of wanting, but there's usually not enough resources. And when they do get training, it's the 1 hour or 30-minute online workplace violence training. And some of these folks are seeing some gnarly stuff, especially in urgent care. Like family practices, I find you're going to get some med seekers, you're going to get some behavioral health people in crisis. But for a good portion of those folks, it's like a stable kind of patient population. You kind of know what you're getting.
Mhm.
Urgent care is just kind of like, I should probably be in the emergency department, but I came here instead. You know what I mean?
Mhm. Yep.
A lot of upper respiratory stuff, but then you get like the smattering of all kinds of other random stuff. And those folks are on their own. Like the police are their backup, right? There's no security. Oftentimes they don't have a ton of staff on, right? And they're all busy. I feel like they often get overlooked for training, for resources, to make sure that the practice is designed for safety, because they got to buy time, honestly. And I talk about doing the calculations, the safety from violence gap, like how much time between the violent act starting and the police arriving do you have? And like, you got to plan for that span of time. Some of these sites that I've gone to are depending on like the state police to come off the highway because they're so remote, right?
Yeah.
And there's like one cop patrolling like hundreds of miles or whatever, and they could be 20 minutes away. So you have to have the appropriate training. Maybe, you have to have people trained at like a security officer level of de-escalation and defensive tactics to get by, or you need a safe room to lock yourself into until somebody can come. But the thing I see most is an absence of training, right? Outside of online training. And I've seen some places that are doing it right. One of my clients started doing 4 hour on-site training. They come to the site, they make the time, and they do a 4 hour training with the staff. And it's gone over really well because I
Really well.
talked to
Is that
people
like
who are.
monthly? Like they're doing that
Yeah,
monthly,
yeah,
or
they're doing like monthly, but I mean, it's
okay.
taking for a long time, obviously, but they have a dedicated trainer, actually two, that are doing that. I mean, they have hundreds of sites, but they're going out and hitting them all. And it's great, and the staff love it. I mean, they need it. And
Yeah.
so that's one of the blind spots. And then I would say training in general is an issue just because of time, right? But I like to see some training instead of no training, right? Most people are doing some level of training. But outside of that, I think over-reliance on technology to solve the workplace violence issue, right, is another issue. Some folks have weapons detection, meaning like the metal detectors, and there's an over-reliance on those that there's no weapons in our emergency department anymore because we have weapons detection. It's like, what about the person that just came in on the stretcher that didn't go through a metal detector, right?
Yep.
What about your staff? They didn't go through a metal detector, right? So, or the person that just snuck in your back door. It's like, the over-reliance on technology and then the false sense of security. I'm not saying that weapons detection is bad, but people need to understand the realities of it, that it's not going to prevent every single weapon from coming into the facility or emergency department. Same thing like body-worn cameras. People are like, we're deploying body-worn cameras. Like, how many videos have you watched of police being attacked on their body-worn cameras, right? Is that preventing violence against them? No. Are there any studies out there that show that body-worn cameras prevent violence? No. Do they have some value in protecting caregivers from false allegations or helping to prosecute people or helping to review situations? Absolutely. But don't give them to people and say this is going to prevent violence, because it's
Right.
not, right? So understand the limitations of the technology. Don't rely on it solely. I think panic buttons are great, but you have to teach staff how to use them right. You can't just give them out. This happens all the time. Somebody buys panic alarms because people are asking for them. They give them the panic buttons. They don't train them how to use them, right? And the staff don't wear them because they don't know like their value. They don't know what's going to happen when they press them. They're afraid to press them. I've gone into emergency departments and all the panic buttons are hanging on little hooks.
Jeez.
I'm like, what are those? What are those for? Those are the physicians wanted panic buttons, so we bought them. I'm like, why aren't you wearing them? They're like, swear to God, it was like a whole rack of panic buttons. Or you go ask somebody where the panic button is, and they start rummaging through a drawer, right? And they pull out this thing that's like this big that looked like it was from like the 1980s with like a D-cell battery in it. And I'm like,
Jeez.
when's the last time you tested this? Tested it? It's like, so it has to be
Yeah.
some kind of if you're going to use
Oversight.
technology, understand the limitations. Like, do the homework first. Don't. It's like what's the saying? Like, it's you're finding a technology and looking for a problem for it to solve versus trying to find a problem that technology can solve, right? So sometimes people are eager to find something that they can point to say this prevents violence, without doing the homework to find out, like, technology is a great way to layer security, but if you don't use it right, or if people like are depending on it solely to solve the workplace violence issue, I think it's a major issue in some hospitals.
Some hospitals, yeah. Well, and I think that goes back to your point too of also making sure you have somebody clinical. Like, is this technology, how is it going to work into the workflow of the end user, who is usually somebody that's clinical? And
Yep.
does this make sense?
Yep.
Right.
Yeah.
And so having somebody involved kind of in those security decisions that has a clinical background can be very helpful. And also I think that's just good stewardship too, right? Like, that's just managing your money well and understanding the workflow of everything. And does this technology make sense for one, for the problem, two, for the staff that are going to be using it?
Absolutely.
Yeah. Well, David, thank you for being here today.
Yeah, thanks for having me.
Yeah, and talking. It's been I've loved this conversation, and I'm so glad that we're connected. Are you going to be at the ACNE, so International Association of Hospital Security and Safety? You're speaking, right?
Yeah, I'm going to be there. I'm speaking on community care security.
Oh, wonderful. Okay, so I will be there. So I look forward to being able to meet
Awesome.
in person.
Same here. Yeah,
Yeah. And then you have 2 books out, correct?
I do. Yep.
Yeah. Where can people find those and get a hold of those? And
On Amazon, and I have one is patient violence prevention and mitigation, and the other one is community care site security. And yeah, both on Amazon, and great resources written as field manuals for not just for security. Any healthcare professional who's looking to make a difference can pick it up, and it's meant to be something you can read and implement. Not a whole lot of fluff in there, just actionable strategies and tactics.
perfect. I've read them. So I got them. I've read them. So yes, I will endorse that as someone that's clinical and reading them. That's very helpful, and definitely no fluff or anything like that.
Yeah.
And then how else can people get a hold of you?
You can find me at my website, dynamicsecuritystrategies.com. And you can, if you're looking to reach out to me, you can find me on LinkedIn. Very active there at dave@dynamicsecuritystrategies.com. You can email me as well if you're looking to get a hold of me.
Perfect. All right. Well, thanks for being here today, David.
Yeah, thanks for having me. Appreciate it.